My name is Samantha Menezes. I'm the General Manager of the Injury Prevention Team at Injury Matters here in Western Australia. I would like to welcome you all to our webinar today featuring Professor Peter Miller. This webinar is brought to you by the Australasian Injury Prevention Network, or the AIPN, as everybody usually knows it as, and is supported by the No Injury Program provided by the Injury Matters and funded by our Department of Health in Western Australia. The AIPN is the peak body for injury prevention in Australia and Aotearoa in New Zealand. They are an independent, non-government network representing all age, all cause injury prevention and safety promotion in the Australasian region. As the region's key professional body for practitioners, researchers, academics and allied health professionals working in injury prevention and safety promotion, the AIPN has a broad-based membership from all sectors of the injury prevention and safety promotion community. It's a pleasure to chair this webinar today on behalf of the AIPN. The AIPN and Injury Matters would like to acknowledge the Australian Aboriginal and Torres Strait Islander peoples as the first inhabitants of the nation and traditional custodians on the lands where we live, learn and work. Before we start, I'll just go over a few housekeeping points. Everyone's microphone should be automatically muted. If not, could you please make sure your microphone is on mute, and this will allow all attendees to hear the presenter clearly. We would love to hear your questions, so we strongly encourage you to please send them through on the Q&A chat box, and we will go through them at the end of the presentation. If you've got more than one person in your room with you listening on the webinar today, we would love it if you could let us know that via the chat tab. Let us know how many people that you have with you and who's listening, and if you feel like it, pop in where you're actually listening from. That would be amazing. If you face any tech issues during the presentation, please write them in the chat box and we will do our best to help you. I've got Joe Mania helping me here today. And also this webinar will be recorded. So to welcome today, we have Professor Peter Miller. Peter Miller is a Professor of Violence Prevention and Addiction Studies at the School of Psychology at Deakin University. He is the Director of the Deakin University Centre for Drug Use, Addictive and Antisocial Behaviour Research, and the co-convener of the Trauma Informed Policing, SIG, GLEPHA. Peter, you can probably explain that one a bit more. Peter has published over 300 journal articles, books and peer-reviewed reports, and completed 5 of the largest studies ever conducted into alcohol policy, licensed venues, violence, comparing 12 Australian cities over 10 years and talking to more than 25,000 patrons. That is amazing. In particular, he is the lead investigator on the Queensland Alcohol-Related Violence and Nighttime Economy Monitoring Study, which is called Quantum, a 13-arm statewide evaluation over 3 years. He is currently running major studies assessing the impact of policy initiatives in the Northern Territory, including minimum floor price and the banned drinkers register, and testing the impact of last drinks data collected in emergency departments to identify and intervene with problem venues across Australia. His other research interests include trauma-informed and shame-sensitive practice, the predictors of violence, including family and domestic violence, and the impacts of childhood corporal punishment. Welcome today, Peter. We are really, really excited to have you and want to thank you for your time. And I'll stop sharing and you can share your screen.
Thanks so much, Sam. Right, I will start sharing. Okay, has that worked, Sam?
Yep, I can see that fine. Thank you.
Fantastic. Okay, thank you again, Sam, and thank you also to the Injury Prevention Network for the opportunity to come and talk about our work. As Sam mentioned, we've been in the space for a while, and it's really fascinating to come and talk about things from different lenses. So it was a great opportunity to bring this together. I wanted to acknowledge that I'm on the beautiful lands of the Wadawurrung people, and I'd like to pay respect to their elders, past, present and emerging, and also their role in terms of the history that they have played and that they continue to play, hopefully more into the future in the Australian community and acknowledge that sovereignty was never ceded. I'm going to talk through today a little bit about what the existing literature and some of the bigger studies around the world have talked about in relation to alcohol and injury. I'm going to talk about some of our nightlife research and those 25,000 people. I'm going to also talk about the emergency department study, which Sam mentioned, because I think that has given us some really fantastic evidence. And then I'm going to flip to alcohol policy and what can be done and what does the evidence say about these public health measures. And coming from an evidence-based perspective, I guess sometimes you can't go past stuff that was written a really, really long time ago. I'm definitely not the first person to talk about the role of injury, alcohol and injury, and I'm certainly not the first one to come up with different frameworks about how much alcohol is going to harm different people in different ways. And I think, as we can see through Dionysi's discussion here, right at the end, when it comes to the hurling of furniture and black eyes, some of these people were going to arrive in emergency departments with injuries. So it's good to know that we've moved on in history to more recent tropes around alcohol and injury. I think some of the best work has been coming out of the World Health Organization and PAHO. And in 2010, so this is a while ago now, but the trends have remained similar or increasing. We saw that the alcohol attributable burden of injuries was very large. Sorry, I did mention to say right at the start, I did acknowledge it in writing, but I do want to acknowledge very much that some of these slides have been borrowed from my wonderful colleague, Professor Tanya Secretsies. She is obviously one of the major influences on my thinking over the past 2 decades and is a great friend, so I want to thank her. So we can see that the burden of injuries, particularly in the Americas, was really substantial in terms of over 100,000 deaths and disability life years lost. Similar to that study, which was actually all led by a lady called Cheryl Sherpatel, who, if you don't know her or haven't heard her, she's just recently won the Kettlebrun Society award for her contribution to research in alcohol. You can see this massive study in 31 emergency departments in 7 countries found a pretty consistent odds ratio between 1.51 and 1.58 in terms of the prediction around injury and alcohol consumption. They found, interestingly, and we've seen this in other places, that heavier drinkers are not as influenced by drinking in the moment and blood alcohol levels because they are more tolerant of the levels that they have, whereas people who are not drinking as much tend to be more influenced in the moment. However, we also know that those heavier drinkers are going to show up more consistently. So it's not that heavier drinkers aren't as much of a problem, it's just they're not as affected by high alcohol or the same levels of BAC, if that makes sense. I hope it does. And we also see that the harm related is greater in societies with greater levels of detrimental drinking as well. We've also seen quite a few controlled experimental studies, and these have been really compelling in terms of the impact. So this is, again, acknowledging Tanya's slides. We know that the controlled experimental studies really show us that alcohol has a substantial and increasing effect with dose related responses in terms of people's focused attention, their motor control, their response inhibition, their working memory, whether they have divided attention, and their reaction time. So you can be focused on a problem, you can make it a lot worse, you can respond poorly, you can respond faster, and you can divide in a divided way, and respond in a divided way, and you may not remember it the next day. So moving on from that, I wanted to talk about the data that I'm going to present today, and particularly from our nightlife studies that have engaged with people on the streets, that have breathalyzed them. We've observed people's Actually, I'll just jump to the next one because that tells you all about what we did. So those studies have replicated or sort of updated each time we did it. We added a little bit, took a little bit away, and sometimes changed some definitions, which you'll see in the next slide. We consistently looked at police, emergency, ambulance data, and in some studies, like the quantum study, we added a huge number of additional data sets. And sometimes that gave us better indicators. But in the end, it really does come back to those first responders around police, emergency, and ambulance. I would encourage anybody who can get access to try and have a look at fire service data as well. I think they have a huge level of harm there too, but it's not being documented. So we've spoken to over 25,000 people. We just recently finished a follow-up one in Geelong. We only spoke to 200 people that time. We still get fantastic response rates, and it's a really important thing in the world where, I don't know about you guys, I never respond to a phone call survey at night. But if you go out and you stand in the streets and you talk to people standing in lines or go into the pubs and talk to them, you can get really great response rates and you can be confident about the number of people. We got around 80% in the last study. So apparently these days, me standing next to the interviewers actually scares people off. There's the whole grandpa effect going on, I think. So we also conduct venue observations, community attitude surveys. We're not doing them that much, and key informant interviews, which can give us a really great understanding of the context. When we talk about experience of harm across all of those studies, I think you can see there's really some quite consistent patterns considering that. So for reference, the Dante study down the bottom there was conducted in 2010. Pointed was around 2013, Dashed was around 2014 to 16, and then Quantum was 2016 to 2020. You can see that there's a change in sexual aggression to unwanted sexual attention. So what we found was when we asked people about sexual attention in those first studies, the numbers were really, really low. And yet, when our observation teams went out, invariably every single one of our observers, our female observers then, and actually it's changed now to all of our observers, were experiencing sexual harassment, so being pinched and groped. And so what we did was we changed the wording to unwanted sexual attention and gave specific examples, so pinching, groping, grabbing, intimidation, rather than sexual aggression, which we think people were actually interpreting as being rape or sexual assault. What you can see here is there's a large proportion of people have experienced physical aggression over the past 3 months. Verbal aggression is higher, and then unwanted sexual attention is the highest. And we've got more data on that coming out now. One of the other things we did was we asked around some of the other issues, and the one that I really wanted to raise your attention about was the one that the big orange arrow has pointed at, in terms of, did you experience alcohol-related injury or accident? And the question went on to say, enough to go and see a doctor or seek medical advice. And we can see that 14.7% is almost the same in terms of levels as the number of people who are experiencing physical assault. So we're seeing a lot of people. These are people who are falling over and hurting themselves, people who are getting injured in different situations, being pushed or shoved or things like that. So we know that the burden of harm on injury alone is also very substantial. And unfortunately, we don't have great insight into a lot of that harm when we talk about people arriving at the dentists on Monday morning, people arriving at their GPs on Monday morning, those sort of injuries that occur later. But in a drive to understand that, but also in terms of trying to respond, and very much in partnership with St Vincent's Hospital, in around 2015, my colleague Nick Drosty and I started working on a project called Driving Change. St Vincent's asked us to come and talk to them about what might or might not reduce alcohol-related harm. We did a literature review and we found that the most effective intervention that could be done at emergency departments was something called the Cardiff model. So this obviously comes from Cardiff and a brilliant gentleman called a maxillofacial surgeon called Jonathan Shepherd, who's still very, very active. And Jonathan created a system of sharing anonymised last drinks data. So the people, the admin people in the emergency department or the nursing staff would ask, where did you consume your last drink? But they also asked the location of the incident. So two really important public health bits of information. And then this information was shared with what they call violence prevention groups. They found large and consistent reductions in violence in and around Cardiff. I don't know if many people have been to Cardiff. It's a city of around 500,000 people. It has a huge nightlife sector, particularly because it has some substantial universities there as well. They found a cost-benefit ratio of around $14.8 per dollar spent, or pounds, and 19.1 for the criminal justice service. So really substantial savings in terms of the benefits of asking last drinks data. And this is contextualized when you think about the average cost of something like a single acquired brain injury from somebody getting punched in the nightlife is around $12 million per individual. So that's a really substantial cost when we think about how that harm plays out. And you consider that about 15% of people going out are in physical altercations. So from that, we developed the Driving Change project. It was an NHMRC partnership. It replicated but extended the Cardiff model. It was a 5-year project with 9 hospitals. As I mentioned, St Vincent's was our lead partner, but also importantly, the Australasian College of Emergency Medicine. We had some indicated brief interventions, so I'll go into that in a sec, and some public health interventions. And really what happened was, this was the process. You enter triage, you asked, have you consumed alcohol in the past 12 hours? My gosh, trying to figure out whether we should ask 12 hours, 6 hours, 8 hours, with the leaders of 9 emergency departments was quite a task. In the end, we went with 12 hours because we felt that would capture most, whereas 6 hours would not capture. And on the other hand, there were still people going to be missed. We then ask how many standard drinks do people use, and this was all around the brief intervention. So we asked whether people had how much they typically drink, and then if it was more than 2 drinks on any occasion, they were flagged for brief intervention. We then went on to ask, where did you purchase most of the alcohol you consumed? And at that stage, it was very categorical. So we didn't give people an option for a text response there. And we wish we had, because this thing called home delivery came along. Yeah, hindsight's a wonderful thing. And then we also asked, what was the name of the place where you had your last drink, including the name of a premises, if that was it. And that was a text box. Then they continue on with the triage process, and for those who were indicated, they would be given a brief intervention, which was evidence-based and was simply a sheet of A4 paper with some information on it. So the findings were that depending on where you went, so we're really looking at this, these are the people who said yes, somewhere between 8% in the leafy suburbs of Melbourne through to 35% in the centre of Melbourne were attending these emergency departments and reporting alcohol consumption in the past 12 hours. People had a range of different responses they could engage in. You can see down here, so they could say, so for people who arrived unconscious, it might be unknown. Some people might refuse. Some would be non-communicative because of their state. Occasionally, there was an ethics question around whether it was appropriate to ask that person in the emergency department triage because of the other people around. But we won't go into that too much. So that you can see for some emergency departments, it's very clearly around 1/3 of the harm that they are experiencing, and 2 of those with higher numbers were regional hospitals as well. So in terms of all attendances, somewhere between 4%, oh, that jumped. Somewhere between 4% and 15% had consumed alcohol in the past 12 hours. And as I mentioned, up to 35% in high alcohol hours. In metropolitan emergency departments, it was about 2 to 3 times higher in terms of alcohol consumption. And what was probably the most important finding out of it was that packaged liquor accounted for 4 out of every 5 attendances overall of the people who consumed alcohol and arrived in the emergency department. So this was a really challenging, especially for an intervention that was meant to be around licensed premises, not supermarkets and big bottle shops. So we still adapted some of the response and were able to look at things. One of the key things to come out of that was that we are now able to document in many ways what are the major issues that are arriving with people are arriving with when they've consumed alcohol. So in this paper in the Australian New Zealand Journal of Public Health, you can see that the most common principal diagnosis after the mental behavioural disorders were injuries to the head, and then further down the list, injuries to the wrist and hand, injuries to the knee and lower leg, and injuries to the ankle and foot. So you can see that if we're wondering about whether injury really matters in terms of from alcohol, you can see that injury is certainly a major outcome in terms of alcohol-related harm in emergency departments. And interestingly, we thought it was quite interesting. The second most common group of attendees at the emergency departments were men over the age of 50 who are drinking at home from bottle shops. So often we talk about young people, and certainly, as you can see below, the data certainly indicates that they remain the sort of largest group. But we do have this group of men over 50 who are drinking at home and literally falling over drunk and hurting themselves, or doing not so clever things like climbing ladders. And so that's really the picture in terms of the relationship between alcohol and harm that we can talk about at the moment. Obviously, we have more data and could go into that for a long time, but really what I wanted to do was make sure that I could switch over and we could have a decent discussion about what can we do to reduce it? What can we do to reduce that harm? What's the evidence told us about that? Because I know that that your network is as much about advocating for change and thinking about that. Now, when you talk to government, they will always say responsible service of alcohol is our way of reducing harm. And the evidence was clear that when you put in place responsible service of alcohol and there was nothing in existence beforehand, you certainly saw improvements in behaviour. But we've got to talk about what that looks like. So the most famous intervention is one called STAD. It's in Swedish, so I can't pronounce it. But the important thing there was they saw massive increases when they put it in. But what was the baseline? Now, the baseline was really interesting because they had a fantastic methodology, which was sending observers in to try and dummy purchase alcohol, to do test purchasing. And the criteria for a bar failing in the STAD project was somebody falling asleep at the bar, spilling their change, and then being served again. So the baseline was very, very low. So you can see that you get that big improvement, but only when you're talking about starting from a very low baseline. But what about the modern day? So in our studies where we did observations, we followed people who were showing 3 signs of intoxication or more. I'll cover the signs in a tick. And what we found was when we followed them around the bar, we weren't that creepy, trust me, but we did follow them and observe them. We found that over 80% across all of these studies that we did, over 2,000 observations, more than 80% were kept being served alcohol. So there was 8% who refused service and asked to leave, but the vast majority continued to be served. And so a lot of this comes down to the different liquor acts. Now, I had sort of deep data around Victoria and also Queensland, so I didn't go beyond that and look at the WA, for example, but it's important to understand that, in fact, the vast majority of our liquor acts are totally unenforceable, and certainly that's the case in Western Australia, Victoria and Queensland. Other states can have slightly better frameworks. But in Victoria, it's an offence for you to be drunk on premises, but not intoxicated. And then when you go and look at, so what's the difference between drunk and intoxicated? They don't say. They just give the same list of symptoms, same list of behaviours, but there's no actually definition for the difference between them. So they go to court and they say, and the venue says, no, 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 he wasn't drunk when we served him. He was only intoxicated. So for every jurisdiction, it's really important to keep challenging these liquor acts, which make no sense whatsoever, particularly where the industry and the government go, but we've got responsible service of alcohol. The answer is you don't, particularly when you look at the Victorian data, which will not exist after Melbourne Cup this year, because drunkenness is no longer going to be a crime. So we won't be able to say 13,000 people were fined for being intoxicated on premise, but not a single venue was charged for serving those people in Victoria. And very much in Queensland, the story a couple of years ago was very, very similar. So in terms of responsible service of alcohol, I think we can say that it's a huge amount of work that needs to be done there. And we need governments to really hold venues who are making profit accountable. Now, one of the narratives that came out and was proposed around doing that was a thing called risk-based licensing. It came from the literature around responsive regulation and the notion that governments could recoup some of the money from managing all of the liquor licenses, and they could charge differential fees for more problematic venues or locations or suppliers. Now, we saw it put in place in all states except WA and Tasmania, but there were lots of different models. Some include compliance within the calculations, some do not. But the basic story is, if you're trading late at night, if you're a large venue, you pay more money for that. And in Victoria particularly, if you're one that has sexual entertainment, you will pay a lot more again. And then you also, if you have a history of non-compliance, so that means if you have a lot of assaults, or if you're, more importantly, if your poster's in the wrong spot, you will get these points against you, and you will have to pay more for your liquor licensing fee next year. And these breaches cost you somewhere between $4,000 and $80,000. $20,000, sorry, in Victoria, which is not necessarily a whole lot when you consider our local nightclub here turns over $80,000 every Saturday night. So it's a question also about how much the cost is. So we looked at when you put risk-based licensing in place, and what we found was really no statistical significant difference. Things did not change in terms of alcohol-related incidents, whether that be Victoria or Queensland. And when we spoke to people around in terms of key informants, we found that ultimately, because there's no monitoring, because the penalties are not significant to the people who are being penalised, there was simply no deterrence effect that they could see. However, there is one really interesting example in Australia around a liquor licensing scheme that looked like it worked, and it was based on the linkage program developed by John Wiggers out of Newcastle, and then implemented, and it was called the Violent Venues Registered, or Declared Premises. And every 6 months, based on last drinks data collected by the police, these venues would be listed, and there would be a public discussion about which were the most violent venues. It was incredibly popular with the media. The discussions would happen every 6 months, and the industry hated it. Now, for those venues who are identified, they would be, as the most violent, they would be given an increased set of restrictions, particularly a venue-specific lockout, and often shots restrictions and drinks restrictions. So what we can see is that over time, we actually saw around a 1.5% decline across New South Wales when other states were going up, and consistently reducing harm. So we do know ultimately that venues can do better. You've just got to find what the right motivation is and what the right surveillance is. So There are lots of other things that don't require all of this incredible mechanism, because enforcing all of these laws takes huge government departments, thousands or tens of thousands of police and liquor licensing people, all to back that up. So what can you do that's a lot cheaper and a lot simpler? Well, simply increasing the price has been shown to work, both in terms of whether it's a minimum price or whether it's an increase in taxation. And there's different arguments and different discussions around both. We know that in Canada, where they've had a 10% increase on the average minimum price, we saw substantial reductions in terms of traffic offences, property crimes, and violent crimes. And violent crimes were lumped together in terms of domestic and non-domestic assaults, but they split about evenly. Similarly, in the USA, where you can look at all these different states and see different rates in terms of, because they all have different policies and they can be right next to them, we did see reductions in terms of a simple 1% increase in price was correlated with somewhere between a 3.1 and 3.5% reduction in wife abuse. Now, the term is terrible, but you've got to put it in context of collecting data over a long time and trying to lump things together in terms of the descriptions. And of course, in terms of price interventions, as I've spoken to many of you before, we have the example of the minimum unit price in the Northern Territory. It was put in place in 2018. It was set at $1.30 per standard drink, and it was specifically targeted to try to reduce or mostly remove cask wine from the picture in the Northern Territory, despite a $1.50 recommendation by the Alcohol Policy Legislation Review, which many of us will call the Riley Review, led by Trevor Riley. And we saw a substantial impact in terms of what happened in consumption. Specifically, it achieved its goal of, reducing by half the consumption of cask wine in the Northern Territory without a correlated increase in any others. So we did actually see reductions across the board in the Northern Territory. We didn't see changes. There has been industry attempts to claim that there's been an increase in spirits and or other things, but while there's been an increase in spirits more recently, that's been most recently associated with changes in income around JobKeeper and the post-COVID era. So we really didn't see a switch to other spirits or other types of alcohol. And when we talk about alcohol-related harm, because of other interventions in the Northern Territory, the only place we can really assess the minimum unit price is to look at Darwin and Palmerston together, because they don't have police officers in bottle shops that were put in place on the same day as the minimum unit price to make my job really easy. But we did see a significant reduction in terms of the rate of alcohol-related assault offences with the rate in population. So you can see a significant reduction there. And then when we also look at across the board, we can see some significant reductions in terms of ambulance attendances. The slope in the graph changed, but there wasn't a significant drop in terms of the numbers, but we saw a change in the slope. And we saw that around ambulance attendances, and nothing really in the emergency department presentations, but we did see that in alcohol-related hospital admissions as well. So some good news, but a fairly small effect. But then you're also talking about a very, very small market. So to put this in context, cask wine was 5% of the alcohol market in the Northern Territory, so a very tiny proportion. Now, in terms of other things that you can do, which are incredibly cheap, if not revenue generating for the community, closing venues earlier. And this is simply shutting the venues at 3 a.m. rather than 5 a.m. or 3:30 a.m., whatever the case may be, has a history around the world. And in Newcastle in 2008, they reduced the trading hours from 5 a.m. to 3 a.m. Then it went back to 3:30 a.m. in terms of shutting the actual venue. And what we saw, so up the top here is Newcastle CBD. Down here is the next suburb along, Hamilton, which this was my colleague Kip Ross Kipri, and he treated next door's suburb, which had an entertainment precinct as well, and it had a lockout. So it had a 3 a.m. lockout, and you can see that there was significant and ongoing reduction in terms of alcohol-related assaults in Newcastle. We did a study comparing the emergency departments in Geelong and Newcastle. Now in Geelong, the venue stayed open till 7 a.m. And there was a range of other measures recommended by the industry, such as ID scanners, radio networks, safety ambassadors, people on taxi ranks, all of those sort of other interventions that were acceptable without changing. And what we saw really comprehensively was no change in relation to that. The measures kept increasing until they flooded the streets with police and they fined everybody who was behaving or misbehaving just a bit. And so from that, we also then saw Queensland adopting that. Unfortunately, the Queensland government, as often happens, they chose to water down the intervention a bit. So they went for a 3 a.m. trading, but they didn't shut the venues. So the lockouts were removed there that were in existence, but the venues and the casinos stayed open. They just didn't serve alcohol. And what we saw was certainly significant findings, but very watered down. So if you water down the intervention, you get watered down effects. So we did see significant reductions in a number of spaces, particularly assaults, but we didn't see that. The other key intervention that we often hear talked about is increasing public transport. So particularly police, because they see what happens on the streets, not so much what's happening in venues. So the police are often advocating, and the industry strongly advocates for the notion, the theory, and many of my colleagues in research have also adopted this position. If you can get people away, you will reduce assaults. Well, the Victorian government went for this. They put in place 24-hour public transport on January 1st, 2016. We were very fortunate. We already had people who had just been out recently doing observations and doing interviews on the streets. The cost of that intervention is around $100 million per year to the Victorian government, and of course that's gone up substantially. But we were able to study it. So we were able to look at it and go, what happened pre and post? We also had, or Victoria has a fantastic system of foot traffic counting on the streets as well. So it was proposed by the government that it would increase the number of people going out in the nighttime economy. And what you can see here is that there is no difference whatsoever pre or post. We saw that this is traffic accidents. And what we saw was there is a tiny and weird little fluctuation around 2 a.m. But again, no significant impact in terms of traffic, but also, and it was proposed, remember, that this $100 million a year was going to reduce assaults in the nighttime economy. And what you can see down here in very gross figures was actually numbers actually started to rise until, again, the police had to be used to swamp the streets to try to reduce the harm out in the nighttime economy. Now, for many people, they didn't really understand why this was happening. We certainly didn't. And it wasn't until we had more data. So by combining in Queensland, we were able to have foot traffic counters, but they have ID scanners on every venue. So we're able to see how many people were going into the venue and when they were coming out. And then we were also able to map that against the assaults. And what we found in terms of time of night was really fascinating. So this is the yellow one, is the number of people who are on the streets, walking the streets. And you could see there's not a massive spike around 3 a.m. when they shut because they just dawdled out. But what you can really see is this massive spike here in terms of 2 a.m. So this is between 1 and 3 a.m. People are in the venues, and that's where the assaults are occurring, not on the streets. The assaults are occurring in the venues. They often then spill out or pushed out by venues wanting to avoid any sort of responsibility. So when somebody says we should put in place free public transport for everybody, it's really a good case of thinking about what the cost is going to be and whether it's going to work. Now, we do know in terms of other very low cost interventions, that reducing potency works. It's been seen around the world, and in the WA we do have one example, though sadly we haven't seen much research on it since the 2000s. It'd be great to see some follow-up on that, but in Fitzroy Crossing and Halls Creek, after 2 years, the government evaluation continued to see reduced severity of domestic violence, wounding, reduced alcohol consumption, street drinking, humbugging, generally a beneficial effect, but I think it's one of those interventions that well overdue. We do have anecdotal evidence in the nightlife space that if you reduce alcohol potency after midnight in nightclubs, you can get reduced harm. It makes a lot of sense, but there's been no systematic or proper scientific trial in that space. And talking about reduced harm, I think one of the important things, particularly for the context of many states in Australia, is to think about what harm reduction could really look like. Having worked in the UK with wet shelters in London and seen the harm reduction response that understands that all drug use is really functional. People are using drugs at problematic levels to try to deal with something. And for some of us, we'll be able to modify our behaviour. I think COVID's been a great lesson in terms of how we respond to certain forms of traumatic events, and how when alcohol is around and we're stuck at home, we might drink a bit more. I think thinking about this for people who come from more disadvantaged spaces and have more systemic trauma in their lives, things like wet shelters and managed alcohol programs. So the difference is a wet shelter is where somebody brings their own alcohol, or alcohol can be provided at a cost, or managed alcohol programs are much more the medical model, where it's very similar to a prescription heroin trial, for example. There have been evaluations, and the managed alcohol program or wet shelter was recommended for the Northern Territory by the Riley Review, but unfortunately hasn't quite come around yet. And I think it's a space that Australia really needs to look at much more strongly in terms of targeted harm reduction for people who really are struggling to control their drinking in this time. We know that whichever addiction we're talking about, it takes many attempts and a long time to deal with a lifetime addiction. And finally, I wanted to come back to one which is so pushed by the alcohol industry that they have a very, very smooth and large organisation called Drinkwise, who have been funded since the Liberal government days of around 2006. When we talk about psychoeducational campaigns, and we're talking about the ones that are trying to change adult drinkers, when we talk about educational campaigns in schools that work on a systematic basis around health, I think the evidence is quite different and promising there in terms of overall behaviour and health. But when we're talking about telling people to stop drinking when you're drunk and don't fight when you're drunk, actually what we see generally is it's mostly about industry PR, and it's not even industry PR for the community, it's industry PR for the politicians and the policy makers. They're the ones who the industry want to believe, no, we're good people, we're doing good things. Look, we all fund Drinkwise. What we have found is that really you've got to have strong messages when you think about smoking adverts. They've got to be out there all the time. I don't know any of you who know of a recent federal government. I know WA government's been doing a little bit, but certainly nothing in Victoria about the government saying, watch out for alcohol. Here are some of the harms. And we also know the thing called the boomerang effect. It's really important. We know that when you tell people, particularly young people, what to do, those people who are going to be good law-abiding citizens are already doing it. Those who have broken the law have already broken the law, and there's about 20% in the middle who are thinking about it, and if you tell them not to do it, they're most likely to go and do it. So we need to be very aware of what these campaigns do achieve and can achieve. So to conclude, and I hope that I'm doing pretty well on the time, I think it was 40 minutes, there's a wide range of effective interventions, but more trials will help. Watering down interventions mean watered down effects, and governments need to be really aware of this when they start pulling things back and saying, oh, maybe we'll let people stay in venues, or oh, maybe we won't charge this much, we'll put less on. Enforcement interventions are expensive, And focusing on individuals has some promises, but they're expensive and have a small impact. Really, when we talk about communities and what you can do, we really need to be talking about planned, substantial responses that are comprehensive, not just knee-jerk responses to some poor child being hurt in a nighttime environment or car accidents or things like that. We need each state needs systemic, multi-layered plans that also considered harm reduction and treatment within that. Thank you.
That's wonderful, Peter. It's so interesting. Oh my gosh.
Now I'll stop sharing if I can figure out where that is.
That's all right.
Gosh. Sorry.
Yeah, that's all right.
Right, stop sharing. There we go. Okay.
I'm just trying to share mine now, so we'll see what happens.
I'll have a coffee. Hang on.
So, no, that was really interesting. And there's so much work to be done, but so much promising work that's happened. So I'd like to thank you and your amazing colleagues, Tanya and all of the others that you were mentioning and that you've acknowledged throughout. Quite incredible work. We've just got a few questions in the box. So I will rip off a couple of them. So Chanel Wilson has asked, are there any Australian jurisdictions with good processes or appropriate resources for monitoring and enforcing RSA or other licensing regulations? And that kind of leads into one of my questions. So, yeah.
So it's been obviously with COVID and the challenges around that. I think it's hard to say now which state might have the best. I certainly saw about 5 years ago that South Australia was able to act on their venues when they were behaving poorly, but I haven't looked at their legislation for at least 5 years, so I can't comment on who's doing well. It's easy to comment to say Victoria is still doing terribly because I know what hasn't changed, and the government keeps ignoring all of the community pressure to try to change things. The Royal Commission on Family Violence said the Liquor Act needed to be revised. It was revised. They made alcohol more available.
Yeah, it's unbelievable. I think my question, I suppose, coming from that was, and maybe this makes sense, is my own young people in my family, so I have a 21-year-old and an 18-year-old, both have done, what can I say, this tick box RSA courses online, and want to go and get a job in a bar, every now and then, which is not something I support, but anyway. However, like, what is it about that high serving rate once they must know people are somewhat intoxicated or drunk? Is it a lack of confidence and therefore workforce development in supporting their staff to be able to say no, or is it just the fact they know that the sort of like restrictions are unenforceable anyway, so it doesn't really matter?
It's sort of all of the above, Sam. So, it's an interesting one as to whether working in venues is helpful or not for kids. I think for some people, working in a venue will be quite beneficial. They go out, they work rather than drinking, and they make money, and they see what people behave like. And some of my knowledge comes from working in the industry. I think I worked as security in industry for about a decade. When it comes to why people don't do it, don't adhere to the response, the overwhelming factor, as we saw in the licensing regimes, is the culture of the management. Now, yes, you can do interventions that give people more training as bar staff to refuse service. Kate Graham's Safer Bars was built on that, and it's the only randomized control trial we know. The problem with that is that people move on from bar work very, very quickly. The vast majority of people who work in bars are gone. So that investment has to be constant, and it's expensive. It's really expensive. But when you have a culture that puts pressure on the managers and the owners financially to say, don't do this, don't allow it to happen, then they don't allow it to happen. They adequately staff the place. They make sure that the staff know that it's not okay for people to be heavily intoxicated. And I know this because I've worked in terrific pubs where that was absolutely the case, where we were clearly told, we don't want this in our bar. We don't put up with it. And we want you to gently help people to get home. But then I've had many bar owners also, as I'm escorting somebody out, tap me on the shoulder and say, no, there's a couple more drinks in them.
Yeah, that's interesting. I think Jenny, I've got a question from Jenny next, but I think she made a quick comment on the chat that also in smaller communities or regional communities, people know each other. So, and I know with my work in the Good Sports program at the Alcohol and Drug Foundation, you know, a lot of the work was around coaching how to support your bar staff to be able to say no to people that they know. So, yeah, it's an interesting challenge, which leads me to Jenny's question. This is a really interesting question around data, and I think a lot of people would be interested in this one. ED staff generally record the primary cause of presentation when a patient presents, for example, a fractured arm, which is the direct result of intoxication, but is recorded as a fracture only. Any advice on how we can get around this in our health system to avoid underreporting of alcohol-related harm?
Well, for WA, I can say rather excitedly that the WA government has invested in one of the, a similar trial to the one I presented before around in rural Perth asking last drinks questions. Unfortunately, Jenny, there's just so many different hospital systems and data systems out there that it's impossible for me to sort of comment on how you could do that better and whether you can include alcohol-related harm in those codings. Certainly, and again, pointing to the amazing Tanya Secretsies, she's done a lot of work around figuring out alcohol attributable fractions. So understanding that actually the most reliable way that we can understand what happens in trends is that by having a look at the level of injuries, just general injuries, and specific times of night, we can use that as the most reliable indicator of changing harms backwards and forwards. But in terms of emergency departments, unless you're doing a dedicated program like the Driving Change Program Cardiff model, or the Australasian College of Emergency Medicine also had a snapshot one where you can just go and do it basically around the country for a night. They haven't done it in a while. And I think it'd be really timely to see it again. That's encouragement, not pressure. But those sort of things can really tell you. So even if you do a snapshot very quickly, one night you go through at 2 a.m. and assess everybody's alcohol levels. Don't do it subjectively. You can't rely on people's judgment of whether somebody's intoxicated. There's really good evidence out there that up to 0.15, a medical practitioner can't judge intoxication as well as chance. So basically, they're really drunk. Yet we have really good evidence from the experimental sector, and a guy called Tom Denson out of the University of New South Wales can demonstrate a measurable impact on aggressive behaviour at 0.02. One standard drink will make you more aggressive. Not mine, his.
That's unbelievable. Yeah, that's just so interesting. I've got a question here from Dr. Rao. Dr. Rao, I will try and summarise this, but I think I might have to just read it off. He said he may have missed this, but what proportion of alcohol harm is from venues compared to what you'd referred to as packaged alcohol, assuming that interpersonal violence in a public arena / venue problem, while packaged alcohol harm is more insidious and people may present with domestic violence where they don't tell us that the perpetrator was drunk. Other packaged alcohol problems present with liver disease and so on, and other organ damage years later.
Absolutely. I can tell you about our findings off the top. So 80% of the harm arriving at the emergency department in these 9 emergency departments, of course it varied a bit, was related to packaged liquor consumption in the home. So that includes domestic violence within that. So it's overwhelmingly these days. It used to be a very long time ago around 60% coming from streets. Now it's 80% coming from home consumption and packaged liquor, only 20%-ish coming from licensed venues, depending again on which emergency department you're looking at. Now, when it comes to police recorded assaults and involvement, we see not dissimilar levels, but of course the police are dealing with things in a slightly different way, and a lot of what police statistics reflect is what police are paying attention to and what they're tasked to do. So because the police are on the street, they will see more street damage rather than being called to a home. If that makes sense.
Yeah, it does. That's great. Krista Coward, she's asked what research is underway re alcohol delivery and its impact.
Not much. Unfortunately, our governments are not interested in funding the research. The retail drinks front body just released their research in inverted commas, and I know that different licensing people think that that's okay, that they would believe that. And of course, they don't even do anything like test purchasing to find out. We are doing some, particularly led by Dr. Kerry Coomber. We have tried, but we have been unsuccessful in getting separate grant funding. I know that the Cancer Council of WA have been driving some, but it's all tiny, tiny, tiny research rather than systemic research that's trying to identify the problem. And our governments simply are not funding it because they don't want to know the answer.
Yeah. Thanks, Peter. I think that about wraps up where we're at, and what an entertaining webinar and just fascinating work, and just want to thank you again. I'll just move over onto our last slide. I think also, Peter, I'll email you later, but there's some questions through about accessing some of the research that you've mentioned as well. So we'll get that out to all participants. So just upcoming injury events are listed on this slide. The AIPN are excited to announce the upcoming AIPN conference, which is scheduled to take place on Monday the 11th to the 13th of March in 2024 at the Sir Howard Morrison Centre in Rotorua, New Zealand. So that's pretty exciting. And the AIPN is an exciting event that brings together leading experts, researchers, practitioners, community organisations and others from around Australia and across the world to discuss the latest advancements in injury prevention and safety promotion. So for the upcoming conference, we're excited to be focusing on the theme, Weaving Knowledges for Injury Prevention and Safety Promotion, Creating a New Way Together. So that's amazing. And I also just wanted to say that they're in the process of forming a scientific committee for this conference. So if you're interested, please reach out. There's some socials on the next slide, actually. And we encourage you to become a member of the AIPN to receive updates and discounts for the conference. So I'd like to acknowledge the No Injury program at Injury Matters for supporting the webinar. And as mentioned earlier, we are funded by the Department of Health in Western Australia and are very, very keen to support and partner any workforce development opportunities in preventing injury and promoting safety. So I think that we are at the end. Sorry, I'm just finding my last slide. There's some socials where you can connect with us at Injury Matters and the AIPN, LinkedIn, Twitter. I think, Peter, you're also on Twitter. Yep, we'll send out his contact details as well. And thank you, everyone, for joining today.
Thanks, Sam.
No problem.